Good morning, everybody.
Good morning, David.
I can't really see you. So I've got some prepared remarks. Thanks everybody for coming out early, and here we are back in Amsterdam. So the Fast Track Initiative and the 90-90-90 targets have provided ambitious goals for shaping strategic plans for funding and implementing HIV treatment, prevention, and support services at local, national, and global levels. And the outcome has, in many respects, been remarkable, with over 20 million people, over half of the people living with HIV, now having at least initiated treatment, and rates of death and new infections have been reduced. However, as more information about the implementation and impact of these efforts becomes available, it's clear that there are problems that are affecting the outcomes. First, funding has failed to reach the levels estimated by UNAIDS as needed to meet the Fast Track goals. Funding for prevention has never reached the proposed 25% of resources that is recommended by UNAIDS. International donor funding for HIV has flatlined or decreased, and donors are withdrawing from middle-income countries where the majority of people living with HIV and of poor people now live. While overall domestic investments have increased, these are not reaching the levels needed to fill the gaps. In Durban 2016, we began to see conflicting information about the impact of treatment scale-up on incidence. As the current UNAIDS report reveals, we are far behind in reaching prevention targets. Treatment alone will not end AIDS. Last summer in Paris, we saw alarming information about rising drug resistance levels. Community advocates are reporting about increasing rates of drug stockouts and shortages around the world, along with reduction in spending for the community support services necessary to ensure good drug adherence. And the data is unfortunately crystal clear. Key populations all over the world are being left behind. Men who have sex with men, sex workers, people who use drugs, migrants, the incarcerated are the least likely to access HIV testing, treatment, and prevention services. Despite a target of zero discrimination by 2020, human rights abuses are increasing while resources for advocacy are increasingly scarce. The growth of a large new population of adolescents and young adults in sub-Saharan Africa presents serious challenges to HIV prevention efforts, particularly as it affects young women and adolescent girls. Meeting the 90-90 targets is not the end of AIDS. If all goes well, over 35 million people will continue to need consistent access to HIV treatment and services for decades beyond 2030. An ongoing commitment to prevention efforts will be necessary beyond 2030 to maintain epidemic control. The time, therefore, to discuss long-term sustainable approaches is now. And where current targets are not being met, and where funding is insufficient to cover the full spectrum of HIV treatment, prevention, and support services, we need alternative strategies, and we need guidance about how to set funding priorities and address gaps when there isn't enough money to do everything. Leading multilateral agencies and donors are by nature invested in their strategies to reach stated goals. It's difficult for UNAIDS or WHO or the Global Fund or PEPFAR or other institutions to openly question their approaches without potentially undermining the momentum of and support for their programs. Yet such questioning is always valuable and essential. We must learn as we go. The Joep Lange Institute felt it could facilitate an opportunity for independent discussion to identify the emerging challenges of the global HIV strategies, describe the need for long-term approaches to the HIV response beyond 2020 and 2030, and make recommendations for improving current responses, as well as shape future strategies. A planning committee was developed led by three chairpersons, Nduku Kilonzo, the director of the Kenyan National AIDS Control Council, Lillian Mworeko, the director of the International Community of Women Living with HIV in East Africa, and Mark Dybul, the director of the Center for Global Health and Policy at Georgetown University and the former director of the Global Fund. An agenda was developed that focused on the following overarching areas: How can we ensure the continued quality of service delivery as we scale up treatment in an era of constrained funding? How can we increase the commitment to and effectiveness of primary prevention, as it is clear that treatment alone will not suffice as a means of epidemic control? And how can funding mechanisms and innovative funding approaches better address long-term needs of HIV treatment and prevention efforts? Over the course of the last year, JLI sponsored 7 consultations to address different aspects of these questions. Each meeting brought together a diverse group of experts from around the world, including people living with HIV, donor and implementing governments, multilateral agencies, donors, healthcare providers, researchers, economists, and advocates. And the results of the discussions are summarized in the report distributed here that hopefully you have, and the full report of the work can be found at jli.org. This wasn't an easy exercise. Some things went well, and other things not as well. I think we've done a good job in articulating many of the challenges we are facing in reaching our goal of truly ending AIDS. And if I think about where we've come over the last 2 years from Durban, just having a space to articulate some of the challenges that we face, I think in and of itself is progress. Because one of the concerns that we had in Durban was that there was really no room to talk about what's not working and how do we change strategies to do things better. But there's no magic bullet in our document. To succeed, we need continued political commitment. Commitment to fully fund the HIV response. Commitment to prioritize our efforts on activities that are proven effective, even if and when they are politically unpalatable. A commitment to supporting the unique role of communities as advocates and service providers, and a real and deep commitment to respect and uphold human rights. And we need, and without these commitments, science, rhetoric, and good intentions can't help us. We really need to be doing the things that we've been saying need to be done since 1983. And we need continued opportunities for dialogues like this, dialogues that are not intended to push any particular organization's agenda, but which can provide a neutral, safe space to question and revise our strategies as we learn more. When I last spoke in this conference center in 1992, I could never have imagined that I'd be standing here 26 years later, alive and well. I could never have imagined that 21 million people around the world would be on very effective HIV treatment. I could never have imagined that we would have such effective tools to prevent HIV transmission. Those of us who have lived through this history have seen remarkable results. Results achieved only through the unique collaboration of governments, scientists, industry, healthcare providers, donors, and activists that have characterized the HIV response. Yet, we must always remind ourselves that our current success is incredibly fragile. We can lose our opportunities and the tools we have created if we fail to use them effectively. If we lose them, then we're back to the horror of 1992. We cannot let our own enthusiasm cloud our need to always question our actions and strategies as we push ahead. So I'd like to thank the Joep Lange Institute staff for their incredible support, to our chairs and our planning group members for their smart and constant input, the Gates Foundation for their support of the process, and the dozens of people who contributed their time and knowledge in consultations. Many of you I already see sitting outside, so hello and welcome. And with that, I'd like to ask Michiel Heidenreich to come up and introduce our chairs. Thanks very much.
So, sorry to interrupt again, but more participants came in, which is great. Welcome to this session. This is supposed to be an interactive session. Can we have the Skiffer slide up back again, please? So we want you to connect, please, to AIDS18.skiffer.com. You then connect. There are 3 options, and you pick anonymous or custom or LinkedIn, whatever way you want to connect. Is it working? and then you're on. Let's test it once so that you feel more familiar with this system. First questions are, what's your type of organization that you're coming from? So if you could give us your votes, please. Give us an idea of who we have in the room. I saw some government people, at least two. Yeah, there they are. Great. Let's see, community, science. I'm always interested in other. Great, wow. This is the second question. Which theme do you find most relevant today to discuss? There we go. Innovative finance, human rights, community-based service delivery. We need to do something about community-based service delivery. And the fashion of the day, innovative finance. Thank you. Now we need to know where you're coming from. So you can type whatever you want, even your street, I was told, which I thought was amazing. But the country, the city, show us where you come from. Thank you. I was looking at the audience, I thought there are way more colleagues from Africa. And Oslo. Thank you. This is just to give you a taste, right, of what Skiffer can do. We'll use it today. Most important, again, for the newcomers, you can use Skiffer to share your thoughts, your comments, your feedback. We're less interested in questions because they just, result in endless discussions. We want your feedback, your opinion, give us your pushback, whatever. That can be done through all sessions, and we'll try to make selections or put them all up and work with it to get a sense of how you feel about the room. And we have some polls for fun. Michiel, the floor is yours.
Yeah, I think actually this is one of the only times that Amsterdam is the biggest dot. But okay. Welcome to Amsterdam all. I would very briefly introduce the first panel speakers. It's Nduku Kilonzo, Lillian, Mworeko, and Mark Dybul. Can you please all come up? We start with Nduku. She is the Executive Director at the National AIDS Control Council in Kenya. And after her, Lillian Mworeko will take over. She is the Executive Director at the International Community of Women Living with HIV in Eastern Africa. And she's from Uganda. Mark Dybul at Georgetown, and also a chair of the Joep Lange Institute. Thank you very much. Nduku, please, the presentation.
Good morning. We've had a coffee, so I'll say good morning once again. Thank you. I was told this is interactive, so I know you always don't say good morning, but I feel this need to be interactive. So thank you very much for being here today. I'm first of all honored to have been a co-chair of this engagement and this discussion over the last 1 year, and that has allowed me to meet many people with very many different ideas, different suggestions about what we need to do, what we could do, but importantly, what we have to commit ourselves to if we're going to get where we need to go. Now, I want to start by saying that when I was asked to talk about a commitment to primary prevention, and make reference the fact that we must have treatment, we must move faster and better on the 90-90-90, but recognize that that alone will not get us where we need to go. So I have no disclosures, no conflict of interest, and I want to start by saying that I welcome you all to Team Kenya events, which include looking at universal health coverage, EMTCT, Youth in Action, 90-90-90, and PrEP. All of them are work that has been going on in Kenya. So karibuni sana, as we say. Take that and put it in your diaries. I want then to look at a little bit about where we are at and what we need to do. And I want to make 3 key comments. And the first one is I want to reiterate that we have a prevention crisis. We must act now. The second is that we have transitions that we have to think about that will affect our work into the future. As David pointed out, we are looking at about 30, 40, 50 years from today, unless we have a vaccine or we have a cure, and we have to start to think about the transitions that we expect over time and what that will mean for our response. And finally, we must reinvigorate HIV prevention programming and financing. So allow me to just make some reflections on why I say that we have a prevention crisis. 75% of the target that we set ourselves out for, if we are to make the progress that we need by 2030, means that we should get to less than 500,000 new infections in the year 2020. I want to remind us we are in 2018, which means that 2020 is 2 years from now. We had 1.8 million new infections last year. The question is, are we serious? Are we going to get where we need to go? And I think just looking at that graph, unless we did something completely drastic, we'll not get anywhere near, we'll not even start heading in the direction that we need to do. And I ask myself why. We have tools, we have the technical resources, we have a lot of people who are invested and interested. We have the science, but we still are not on track. And the truth is, the pathway that we have doesn't seem to be taking us where we need to go. Only 38% of people living with HIV are virally suppressed. And we know that if treatment is going to work, we must get viral suppression to the levels that we experienced in the studies that told us treatment was prevention, particularly HPTN or 5.2. Condoms, we know condoms work. When they are used, we are no longer investing in them, and we cover less than half of the need. Young people do not have correct information. 43% of the countries with documented injecting drug use do not have harm reduction programs. Coverage on voluntary male medical circumcision is low. PrEP coverage is way, way, way below target. Populations have been left behind. And on EMTCT, we are far, far, far away from our goal of prevention, not just elimination. In the context of all of this, our resources are declining. So we want to get fewer than 500,000, but you can see I've put a little line there. It's a little invisible because it's meant to say that we have an invisible space that we are not seeming to get through. And until we do that, we will not be able to get where we need to go. When I think about EMTCT, I think about the targets that we have. This is an area where we have had significant political commitment. It is an area where we have had significant engagements, where we have had resources being poured, where we have had a lot of energy. Yet we still are way off track from the global plan target of 90% reduction. Many countries have not even met the 5% reduction, have not gotten to less than 5% of all children who are born of HIV-positive mothers being born free of HIV. And so I think we are in a space where, regardless of a lot of effort that we have put in, we have a crisis, and it is a prevention crisis. I want to talk about some of the things that will affect us moving forward. And I want to think about the transitions. I want to start with demographic transitions, and I want to put that, which I sourced off the UN Population Division. And Africa has the highest HIV burden. It has the highest number of young people, growing people. It contributed 65% of the new infections in 2017, and of the total number of new infections in adolescents and young people aged 15 to 24, 60% were from Africa. And that is the blue line that is on a steady upward climb. Now, essentially, what that means is that even if we had the same rates of new infections that we do over the next 10 years or over the next 5 years in Africa would double the number of newly infected people just based on demographics. In other areas of the world where you have a larger aging population, We have more people who are growing older, living with HIV. The treatment needs become increased. We have non-communicable diseases, which are the new comorbidities for HIV and AIDS. And therefore, we are in a space where we have to reconsider how we are going to be able to deliver on prevention and, importantly, on treatment and the quality that is required, given the resources that are significant that are going to be required. I want to talk about global epidemic transitions. Whereas we have the highest and highest numbers of new infections in Africa, I think I also want to make us reflect on where we have had the highest rates of increases in new infections. And that has been in areas where you have underserved key populations. And as the map can show you, we have a lot in the Eastern European region. And we have to really think about what this means about the future of the HIV response. Is this where we'll have a great future burden of HIV? Yes, if we do not do anything about prevention now and reach the people that need most to be reached. Most of these countries do not have key populations programs. So thinking about the populations that have been left behind, it is easy for us to focus on a few populations, but I want to posit here that if we do not think about different populations differently, in the context that we start to say that anyone who is left behind means that tomorrow we'll be talking about them and those populations and people, our brothers, our sisters, individuals with faces in those populations as the people that tomorrow become newly infected. We have young people, we have prisoners, we have migrants, we have sex workers, people who inject drug use, people living with disabilities. And I welcome you to the youth session in Kenya, where we have young people living with disabilities speaking about their HIV response, displaced persons and children, pregnant women, transgender people. I think what I'm saying is that we have a large segment of people that we don't think about, that we have to think about. In Kenya, we keep thinking about population, fisher folk. My final point is that we must reinvigorate HIV prevention programming and financing. I have spent time talking about what's not working, what is wrong. It doesn't mean that we haven't worked. It doesn't mean that we haven't seen significant progress. I wanted to be able to raise the fact that that alone will not get us where we need to go. But we do have opportunities from history that we can rely on. So I want to talk about treatment as prevention, because this is one of those areas where I think we have come to a place where we have created a false dichotomy between treatment and prevention. In effect, they are two sides of the same coin, and that coin is the HIV response. We know that treatment alone will not get us where we need to go. We had the 96% protective effect of treatment as prevention. But I want to note several things. The first one is the first 90, which must be achieved in order to get to the last 90, is off track. We are not finding the people that we need to find for all manner of reasons. Some of them are difficult to find. We haven't invested enough. They are underserved populations. We also know that data, phylogenetics data currently tells us that our HIV acute infections, which is where most new infections occur, we've not yet made significant progress in finding newly infected people. And this goes again back to the first 90. I also want to note that the second, which is the viral suppression levels in real life, are not concomitant to those that we saw in the studies. And therefore, which means that we are still way off from the second and the third 90s, even if we achieve the first 90. All of these things mean that we are not near to being effective in ensuring that treatment gets us where we need to go. We must invest in treatment. We must increase coverage of treatment. We must increase the quality of treatment. We also need to recognize that we must invest in primary prevention alongside. When I think about primary prevention, I think about some of the things that we left behind. And one of them is multi-sector action, action between sectors. And I want to speak to Kenya. Between 2013 and 2015, we had an overall 19% reduction of new infections across different counties. And we began to map out and granulate the data at subnational levels. And we noted that there were counties that are low prevalence, or as we know them, low burden. But over the last, within the period of those 2 to 3 years, they had increased the numbers of new infections by more than 50%, some as high as 200%. What we realized is we started to ask ourselves, in those areas, why, what happens? And for each of those very, very red areas, the first thing that I want to bring note to and take note is that we had significant infrastructure projects. We had a huge railway project that ran from the coast of Kenya right across the red area that is towards the south from the coast all the way into Nairobi. We had a huge project that was a new transport corridor that ran from the northeastern part of Kenya, where we now have oil, right down all the way to the coast. So what this meant is that road corridor was actually, and when we did heat diagrams, we realized that data and the data on new infections actually was hottest, that is reddest, along the actual infrastructure. And so we began to ask ourselves, so where should we be investing? I think multi-sector action is something that we have left behind in the HIV response. We have gone back to being a primarily health sector-based response, and yet we know that it will not necessarily sexual practice happens outside of the health sector. It happens where you have migrant labor. It happens in parties. It happens in communities. And so we need to start to think about other sectors and invest in other sectors. In addition to investing in programming there, we can also find additional resources. For instance, in the education sector, where I know in Kenya we have more than about 200,000 young people in the education sector who are living with HIV. We could influence policy and financing so that we we include HIV prevention and treatment costs as part of the capitation budgets. What would that do for ensuring that there was resources in that sector? Do we have to actually have a new budget line for HIV, or could we get budgets from there? When you think about the infrastructure sector, which I've just talked about, which always has resources that are attached and that are committed to mitigating health impacts, shouldn't we look at what those resources can do for HIV? And we did a very basic costing, and they ran into billions of Kenya shillings, which is millions and hundreds of millions of dollars. So I think we need to start thinking differently and going back to where we came from. The other item I want to talk about is education, community action, and this is part of a story that we will keep hearing throughout this conference, but it is going to be essential for us to reinvigorate prevention. Community action. Let us not desert what works. The story of condoms. We know condoms work. We just know that they don't work if they are not used. But are we investing enough in getting them to be used? Are we investing enough in getting people to think about condoms, to use condoms? Are we investing enough in access? Are we investing enough in uptake? Are we investing enough in creating demand? Or have we moved on? Know your status were campaigns in the early days. We moved all our campaigns and testing from communities and brought it to really institutionalize at medical and health facilities. Important, yes. But by looking at them as competing rather than as complementary efforts, we are in a place where the first 90 is not being met. So I always use this example or this quote that was given by Dr. Mokoma, who is here, and I say that in Kenya, our mobile phone penetration is in the 90s, 90% in the general population, and everyone knows there's something called a Bamba 20, which is a 20 shilling little caption that you can get to be able to load your phone. I think every single Kenyan, every single young person, because doesn't have much income, knows where to get the Bamba 20. 20 shillings would be equivalent of 2 cents in the dollar. Knows where to get that. Why is it that every young person does not know where to get a condom if they know where to get a Bamba 20? This is what we must do differently. This is how we must think differently, because those Bamba 20s are available to the lowest levels of the community, and they are supported through a community network from the private sector. So we must invest in community action. We must think about how we contract with there is need for documentation of civil society reporting mechanisms, and clearly, currently, where where I sit, we lack systems that demonstrate community contribution on an ongoing basis. There are a lot of excellent engagements, there are a lot of excellent reports, but on an ongoing basis, standardized approach that can be able to say for all community interventions in Kenya, this is the contribution, this is what is happening, that is currently lacking. And until we get there, it will always be a question that we have to deal with around how best do we engage. Finally, I think as I move forward, I want to talk about delivering HIV prevention consistently and at scale. The HIV Prevention Roadmap 2020, Global Prevention Roadmap 2020, gives us a 10-point action plan that touches on many of the items I have touched today. But we must strengthen enabling policy, and we must really start to talk about a real commitment to equality, to equity, and to human rights. We must be able to think about scaling up interventions that work, that are non-judgmental, with access, follow-up, and reporting mechanisms, and we must be able to look at what works and how we are going to deliver it. For instance, HIV PrEP. We must look at financing of services. As I finalize, I want to say, moving forward, we must think about the first 90. We must protect the quality of treatment. We must reinvigorate HIV primary prevention, scale up what works, and do it consistently. Think about cross-sector action, invest in condoms, in addition to new prevention interventions, such as HIV PrEP. We must strengthen our commitments to equality, equity, and human rights. I want to acknowledge a lot of people who made this presentation work and for all the work that has been done into getting the report that we have today. Thank you very much.
Thank you very much, Nduku. No questions now, please. We continue immediately to Lillian, our second speaker. Thank you very much.
I'm not sure if I'm on. Yeah, my work is very easy now, starting from where Dr. Nduku ends. She has told us we have a prevention crisis, and I'm sure nobody doubts that. But I think the crisis is bigger than what she's talking about. And through the project that David talked about elaborately, we've really found that there's a lot that needs to be done if we have to realize the 90-90-90. And of course, 90-90-90 leaves 10-10-10. But when you get into the details, then you realize that there's a lot that needs to be done. So I don't have any conflict of interest to declare. But probably by the time I end the session, and if that comes about, then I'll see how to go about it. So where are we, and where do we want to go, and how can we ensure that the 90-90-90 is better and gives us the results? It is important that as we discuss all these issues, and as we heard from different people, categories of people, different populations, quality of HIV treatment is very, very important, and it came out clearly. We cannot underscore the fact that community-based service delivery and advocacy is what has led us to where we are, and therefore it needs to be scaled up. And it is very important that we reflect on primary prevention. We've done quite a lot, but now we need to get to the basics and talk about invest in primary prevention. And I'm glad that at the beginning of the session, it was very clear that people want to hear more about funding, and therefore we cannot do anything much better without a sustainable and equitable funding approach. But also all this, and I'm glad that, again, Dr. Nduku has taken us that step. And my role here will be to be addressing why we are having a crisis, why we are leaving some people behind, and why we are having challenges in delivering to our expectations. And therefore, I'll be speaking a lot about a commitment that we need to invest in human rights protection. And I cannot say this more than David did. Key populations in relation to the 1990 goals, where are they? Adolescent girls and young women and young adults in general. You've seen that there is quite a lot in terms of even prevention. We've talked for quite long about drug resistance, stockouts and shortages, the healthcare system that is overburdened, where we have shortages of healthcare workers, and where they are not well motivated. But we also know that we've achieved the results that we have because we invested in communities. I know all the work that we are doing has a legacy in what the aid support organization TASO in Uganda did by investing in communities, by investing in people living with HIV. And therefore, where are we now? How are we learning from what we did then and what we are doing now? I don't want to speak so much about this, but as you can see, when you look at the cascade of treatment, you realize that we are not doing well. And if we are not doing well, if we are moving down instead of going up, then there's a bigger problem. There's a bigger problem and probably a bigger crisis that we must be addressing. And of course, we are seeing that a lot of new HIV infections, for example, are happening amongst key populations, including adolescent and adult youth. This is where HIV is, but when it comes to programming, when it comes to resource allocation, when it comes to issues around our legal environment, then it gets even worse. And therefore, if we have a population that is highly impacted by the burden of the disease, and yet they are not able to come out, what is it that we are talking about? And this just gives you a snapshot of what is happening around the world. That day by day, instead of reducing the number of countries that criminalize HIV, sex work, and people who have same sex, we are instead increasing on the number. And tomorrow there is going to be a whole day session around criminalization. So it does not make it any better, and therefore we cannot get better results when people know they are going to be criminalized. And therefore it starts from the fact that the moment one knows they are going to be criminalized, they'll definitely not come out to be tested, and therefore we won't know their status, and therefore we cannot even prevent. And even when they know, they will not get into healthcare facilities because they know they are going to be tracked down, and the story goes on and on. And therefore, we need to be looking at 90-90-90 within a context, within the environment that we operate, within our legal policy environment, especially in countries where we know HIV is criminalized, where we know all these groups are criminalized. And at the same time, these are the countries that are registering high new HIV infections. And therefore, we have a missed opportunity because we know evidence has shown us what needs to be done, where we should be investing our resources, where we should be investing our energies, but we choose to do things differently. And of course, talking about adolescent girls and adults and young women, for example, when it comes to viral suppression, because we've just heard about the importance of treatment as prevention. But you cannot prevent, you cannot treat to prevent when you're not suppressing the viral load. And this is what we are seeing in most parts of the countries where especially we are registering high new HIV infections. This one I'll not speak to it. It has already been alluded to. And of course, you cannot prevent through treatment if people are not adhering. this we have seen, and there are so many barriers to adherence, including individual, and that is where we've concentrated much of our efforts. We've concentrated a lot, for example, on looking at self-stigma. And when you talk about stigma and discrimination, that's where much of the effort is. But we also know that there's institutional barriers. Like, for example, I've said criminalization. People will not get to facilities if they know they are going to be criminalized. We've registered a lot of, we've done a lot of studies around coerced sterilization of women living with HIV. And therefore, women who are HIV positive and they get pregnant, they fear getting to facilities, and therefore this fails elimination of mother-to-child transmission. And the story goes on and on and on. And therefore, it makes it very hard to realize all the 90s, because you cannot get to know your status. If you know your status, you cannot access the services. And if you access your services, you're not adhering, and therefore, all the 390s are not getting better, but getting worse. Of course, I've started talking about this, but I think one of the key things that I just wanted to share with you is 2 weeks ago, we did a consultation in Uganda with young women of up to 34 years, 18 to 34 years, and we were trying to look at the guidance from WHO and what my country, Uganda, is about to issue out in terms of use of DTG. And we are trying to understand the perspectives of these young women, some of them using DTG currently, and what we got, and also that shocked the ministry, is the information that the young women were bringing out, to the extent that even when some of us, when we started treatment, and for us it was a matter of life and death, and therefore anything that came our way, we took it wholeheartedly. Even if there were side effects, we were ready to say, we shall go with this in its entirety. But what we heard from young women, and of course what we have known, but this time it was real to the extent that they were saying, we need a drug that is going to work better for us. If it is not there, then we are ready to go by anything. And there were these young women who are like, I need a drug that is not going to make me continue having dreams, but I need a drug that I'm going to take and I sleep like any other young person. And sex workers were good enough to tell us, yes, we've been taking efavirenz, but since we started taking DTG, life has changed to the extent that I work at night, and therefore I need a drug where when I'm going to be awake, I'm not going to be dizzy, I'm not going to be moving around, and I need to be rested. And therefore, these are some of the things that we need to be looking at when we talk about 90-90-90. What is the quality of treatment that people are getting, and how are they adhering to it? And also the belief and the thinking that everybody is the same, we need to change from that, because some will say, whatever it is, I'll take it, but others will say, wait a minute, I have a right, I need a choice, and I need a better regimen that is going to make me comfortable. Of course, these slides are showing us in terms of also what we have talked about for quite long, the stockouts. Why are there stockouts all these years? Why do we still continue to register stockouts? It is a question that I think you should be helping us to respond to. But one key important factor that is critical is that many times we say there are drug stockouts. There are stockouts in the respective countries. But we never go deep into asking and understanding why probably these stockouts happen. But I think also one of the key things that personally I have reflected on is that many times the countries are also struggling, to the extent that recently we were talking about PrEP and how we would need PrEP scaled up in my country. And one of the key things that came out was, if we told you to stop treatment so that we have more resources to invest in PrEP, how would you feel? Of course, that is intimidating, but it was more to make me realize that there are decisions that are being made at country level that probably are beyond the countries to the extent that they have to make hard decisions. They have to make hard choices, especially if you have a group of people who are on treatment, who must remain on treatment for life. How do you say you're going to limit that number, or you're going to continue having them on treatment, but at the same time invest in prevention? And therefore, we need to think around the hard decisions that countries make, the countries, especially the poor countries, and the countries that, for example, are now being transitioned by the Global Fund. And therefore, for me, that is very, very important, and for us. And this is what people reported. Of course, we are talking about healthcare worker shortages. And here we are talking about differentiated service delivery models. But we also know that there isn't a lot of investment to making that happen. And therefore, countries are going to continue struggling with the healthcare workers who have a lot of things that they must invest in. Because now we are talking about integration. Of course, integration is meant to reduce on the number or on the areas that a healthcare provider is going to focus on. But it takes more time. If a health worker is going to talk about HIV, is going to talk about hormonal contraceptives or contraceptive use, if they are going to talk about all these things, it means that there has to be enough time that the healthcare worker is going to give a patient or a client. But what do we see? That we don't see numbers increasing. We don't see an investment in how these healthcare workers get motivated, and therefore we continue to see the same challenges, and we continue to talk about achieving 90-90-90 with the same workforce. Of course, the community-based responses are very, very important. Like I said at the beginning, most of the work and achievements that we have is because we invested in communities. We invested in people. We invested in groups and networks of people living with HIV. But we are seeing a reduction in that investment. And we don't see our governments, we don't see the donors putting a lot of effort in that. And yet, that is where we can get results. I remember in most of the conferences that I've been at, the community action is what has led to changes that we are seeing. But to the extent now that that investment is not there, then the next question is, how do we think we are going to realize the results that we need? And therefore, we need to think about investment in those communities, investment in the communities. And of course, drug resistance is becoming critical, and yet we are not seeing an investment in that. And therefore, we need to challenge the World Health Organization, the governments, the WHO and UNAIDS to invest in addressing issues around HIV drug resistance, because if it is not controlled, then we are heading for more doom. And of course, the mobile technology, like we started this session, I think that is the way to go, especially if we have to capture young people who are good at that, and we need them in the response. Yeah, I think that's it. Thank you.
Thanks, Lillian. Mark, please. Yeah, you know this.
I think I have the right one. I might have clicked on the wrong thing. Let me just look. Yes. Yes, okay. Good morning. Before the report, which hopefully some of you will read, at least the executive summary, is divided into sections, and we're going through the different sections. So one was about how we have greater focus on prevention and the epidemic itself, and on efficiencies and effectiveness and reaching the people we need to reach. And one section is on financing. So that's the section I get to talk about. I get dumped into financing all the time now after running the Global Fund and PEPFAR. But I did want to emphasize before that if these things are linked, if we cannot get control of the increase in infections, which we are going to see because of the demographics in South and East Africa in particular, and in key populations, particularly in Eastern Europe, there will never be enough money to respond. There will never be enough money if we cannot get the infection rate down. So if we can't use the systems that we have and tools that we have to get a hold of the epidemic, and I keep saying and getting in trouble for it, we are probably at the highest risk ever of losing control of this epidemic because of demographics and because of countries not paying attention the way they once did, or never did in some cases. There is no way to pay for this for the long run. So with that as a lead-in, we can talk about financing of the response. This is a project that David talked about, and again, this is the summary of some of the key pieces which we're going over, and the financing piece is the one that I'm going to talk about. The big summaries here are not going to be surprising to anyone. We're not meeting the needs that we already have said we need for fast track. Middle-income countries are having difficulty catching up, although when we look at the data, it's really low middle-income countries where we're having the biggest problem. Key populations remain underserved, which we've heard about. So let's get to some of the data. These were published in PLOS Medicine. We'll get to some IHME data, UNAIDS has data, but it basically is all going in the same direction. The red bars are where we are. The blue bars is what we say we need. Now, if you look in low-income countries, we're actually getting pretty close because there's a fair amount of external financing as well as some internal financing. But when you start getting to middle-income countries, things fall apart pretty quickly. Especially if you look at upper middle-income countries, what the bars also show, which the IHME data also show, are that as countries get wealthier, they actually increase their own finance. Now, some of that is because of the decreased external financing, but every country has gone through this pattern, including this country and including high-income countries. As you have more money, you can spend more money, and your systems get better to collect more money. So the money is going up in high-income countries, upper middle-income countries, but it is not keeping pace, in part because of the decrease in external financing. But low middle-income countries, not surprisingly, because they have less money than high-income countries, have a very low, are very low. If you look at what's happening in external finance, I really hate the word donor, so I'm going to try really hard not to use it. It's a paternalistic, horrible word, so I'm just going to say external financing. So if you look at external financing, there's a significant drop-off from 2012 to 2015, as you can see in the upper bar there. I would point out, however, and these are the data from IHME, I would point out that this is in US dollars. And as we all know, in that period, the US dollar got very strong, which means if you don't convert or if you don't account for foreign exchange rates, it looks a lot worse than it actually is. Most countries actually, donors, most external financing, give in their currency, of course, because they don't have US dollars as their currency. So it looks a lot worse than it is because this is US dollars. But nevertheless, we are seeing a significant drop in financing. And we will continue to see that drop in financing as countries get wealthier and as they need to take on more and more of their responsibility. But the trend is unquestionable and not going anywhere, and not going to change significantly in the near term. If you look at low middle income countries and who's financing what, the external financing is really about 43%. External financing is really 43%. 57% is coming from local, which we just saw, domestic financing, but it can't keep up, as we saw as well. If you look at high-income countries, not surprisingly, you have even less, about a third of the resources are coming externally. And this is the way it should be, as long as the resources together are reaching the places we need them to get to in order to achieve the targets. Now, the purpose of money is to have impact. It's not just to have funding. So if we don't keep up with the funding, the projections are pretty simple about what's going to happen. We're going to see the epidemic getting worse, a lot worse, not just in treatment, but in prevention. And if we're behind already and at risk of a greater increase in new infections than we've ever been because of demographics, you put those two together and you have a crisis of epic proportions. Literally, we could be back literally to where we were 15 years ago unless we get ahead of this and get ahead of it quickly. More data basically showing the same thing, that bad things are going, simple, bad things will happen if we don't have more money. It's just putting this in human terms, because we just talk about billions and billions, and we should, but if you just look at, and these come from AMFAR and AVAC, and this is important for policymakers to understand, that and I mean policymakers from external financing as well as internal, that there is concrete effect of less money in terms of people's lives. It's not just about money, it's actually about people's lives. And it is useful to have these types of data, at least I found, for policymakers to be able to show what a cut of X amount means in terms of an outcome to a human being. And then if you add to that what will happen over time and to the loss of control of the response, you can start getting people to pay attention. So what do we do about all of this? Well, there's been the reason this project overall took place is because we felt fairly strongly, and I think still do, although there's a lot more conversation at this conference than we've had in the past about where the problems are. Where are we not achieving success? Which is fun. We can at the same time celebrate the tremendous success that we've had and question the future. How are we going to make sure that success continues and go forward? We can walk and chew gum at the same time, as President Obama once said, about something else. We can talk about success, but also talk about challenges at the same time. We've talked about some of the programmatic challenges. The financial challenges we do talk about. There are lots of meetings about, and we're going to talk about innovative financing, but we usually have the wrong people at them, including me. We have public health experts talking about finance rather than finance people. Fortunately, we have John Simon and Anno and some other people here who actually know finance well. But these conversations are not particularly useful in many settings yet. So what we talk about a lot is innovative financing. The reality is the vast majority of it isn't particularly innovative, or at least the majority that's going to have a high impact is not particularly innovative. So I want to talk about some of the mechanisms that are talked about and that are necessary that might be innovative, but really they're just basically what countries need to do to finance their epidemic, or finance health more generally. The main point I want to make, and I'm going to come back to this, is countries are actually quite far ahead of us in the global conversation. Listening to Nduku and Lillian, you will have a far more sophisticated conversation, and they did have a far more sophisticated conversation about what's happening with their epidemic than you'll ever have globally. Same thing in finance. When you listen to the countries, you actually hear something much more detailed and much more refined than we ever get to in global conversations. With that caveat, above the red line are basically things that can be done that will have impact in billions of dollars. The first is taxes, countries collecting taxes and using them for healthcare. That's going to be the basis for financing HIV response, and it's going to be the basis for countries to be able to fund their health and HIV programs. There are some things within taxes that people can do. That means countries need support so that they can collect sufficient taxes, which means understanding who should be paying taxes and how to collect it. Those systems are not public health systems. Those are finance systems. There are some creative things some countries have done. They're called sin taxes in general. on alcohol, cigarettes. Cigarettes might be the most important because the data show that taxes actually reduce use of cigarettes. So not only can you make money, but you can have an impact on your health system by reducing the use of the cigarettes. Hopefully, at some point, you won't collect any taxes because we get rid of one of the things that is killing more people than anything, which is cigarettes. But however, these will, although we had some examples in the early days with Zimbabwe and other places using taxes specifically for HIV, that era is kind of over. The taxes that will be done, if sin taxes are done, will be for health more generally, as it should be, as long as HIV gets a share of that. Some countries are looking at really creative things. The Cabinet Secretary of Finance for Kenya a few years ago was actually looking at carbon tax credits to pay for health. Highly creative approach. Might not go anywhere, but countries are thinking about really interesting ways to try to finance things. The second area relates to taxes, although you can supplement tax financing through insurance. And in the end, there's no way we'll reach universal health coverage and the HIV response funded without insurance, or some form of insurance. Public or private, as we just heard, there's a lot of private providers, and there's a lot of healthcare provided in the private system. So if we get too dogmatic about it has to be public versus private, in certain countries it's going to be very difficult. So if we're agnostic on that and go country by country, what we need is insurance. Something that can be done today is risk pool protection. So if you're in a country in Southern Africa or Eastern Africa, the way insurance works, as you all know, is young, healthy people pay for older people that get sick, or very young people that get sick. Well, if you have a massive explosion of HIV and a demographic bulge of young people, and they need HIV services, your risk pool falls apart pretty quickly. Or if you're in certain states in India and you have a high rate of tuberculosis, or Indonesia, you will destroy your risk pool pretty quickly. So for now, it should be possible for external financing for some of these diseases to help protect the risk pool so that can grow to a certain point where it can absorb, the risk pool can actually absorb those costs. That kind of support and modeling would be highly useful to some countries. How you tier premiums is a great struggle for countries. They're all trying to do it, but they don't know they don't have the systems to understand whose income is at what level and how they can tier and therefore raise the premiums in different areas. Rwanda actually has done some interesting work, as have some other countries. There's crowd financing, which is a form of insurance, which Farm Access Aunos here is working on in several countries, which is a form that using technology that will allow friends and family to help finance healthcare delivery through online mechanisms. So technology can help with a lot of this, including trying to understand and build the data systems that allows for an effective insurance system with risk pool protection. Another big area that can be used is loans, where appropriate. Now, those of us who promote loans get in trouble all the time. Not every country can take a loan, but I do think we ought to remember that every country that gives to the Global Fund or that gives in a bilateral program is taking loans effectively to pay for that. There's not a single high-income country that doesn't take massive loans every year, and they're paying for their government services with that, including their ODA, including their support to external finance. So loans can be effectively used. They can't be used everywhere because you don't want to build the debt, but India has taken and paid $500 million in loans from the World Bank and paid it back and increased their HIV and TB services by doing that. So where appropriate, you can take these loans out, and then you can use buy downs or using external finance to pay for the premiums on those so that you can actually pay for that over time. This is a controversial area, but it can be done, and actually in Central America around malaria, they just did some really fascinating stuff using Global Fund buy down money to allow for getting to malaria elimination with the Inter-American Development Bank. Efficiency and integrated service delivery with universal health coverage has been talked about. Without greater efficiencies, there will not be enough money. A big part of the Joep Lange Institute work actually was around this, but it's not the area I'm supposed to talk about. So these are, above this red line, are things that have to be done if we're going to fill gaps. There are other things that usually take up most of the conversation of innovative financing, like social impact bonds, other international designed approaches, philanthropy, especially for key pops and key pop funds, really important things. high transaction cost, and will raise tens to hundreds of millions, not billions, but still useful tools in certain settings as long as they don't take away from other things. So key actions are to support the countries to understand the costs and of control and ending epidemics, and also the opportunity cost of not engaging in that. What is an equitable share depending on your income level of domestic finance versus international finance, and how do you design the best mechanisms for a specific country or region and so that you can put the right package together. And while some of these packages will be more relevant for lower and upper middle income countries, if you don't start when a country is in low income status, you will never actually get to them. I'm not going to go through this because we don't have time and because it's in the report, but we have a lot of very specific recommendations, none of which are particularly new or innovative, but it's important that they be in one place. My favorite slide. I don't have it. I would say the most innovative thing we can do is actually listen to countries. One of the most impressive things that happened in the consultations we had was we had a bunch of international partners talk about the mechanisms they'd created, and then we had the countries, and we did this in Nairobi appropriately, we had the countries, 3 countries, present what they were doing, which was a decade ahead of where the international partners are. So instead of us trying to design things and say, here, go use it, even though it might not be at all relevant for the country, why don't we actually get the countries together, finance and health, and ask them what they're doing and what they need support on and what kind of international mechanisms would actually be useful to them. Wouldn't that be innovative to actually listen to the countries? So why don't we start there, and then we can probably solve this problem. Thanks.